Hello, my name is Jone and I'm a perioperative medicine fellow at UCLH, and together with consultant Dr. Isra Hassan, we would like to present our quality improvement project to improve perioperative nutrition plans by reducing discrepancy. As we know, nutrition is a key part of ERA's protocols, and it plays a major role in supporting recovery and reducing complications after surgery. But for nutrition to be safe and effective, the plan must be clearly documented and consistently followed. Poor communication can lead to delays or even harm if the feeding is started too early or too late. At our hospital, the surgical team sets the nutrition plan. This plan then is handed over to an aesthetic team, which hands over to our PACO team. To improve clarity and teamwork, we introduced a color-coded magnet system. Each magnet is placed at the patient's bedside, helping all staff quickly identify nutritional status. We carried out our audit to check how well the magnets were used and to understand why discrepancies in nutrition plans were happening. We divided our audit into three main stages. First, we looked whether the magnets were actually present at the bedside to indicate patient's nutritional plan. We found that unit was compliant about 75% of times. When magnets were missing, the main reasons were unfamiliarity with the initiative, particularly among new staff members, high workload on the unit, no documented nutrition plan available, or contradictory instructions given. Next, we examined whether the magnets were matched the documented feeding plan. Discrepancies were mostly due to differences between recommendations made by surgical team and an aesthetic team. And lastly, we assessed who was responsible for documenting the nutritional plan. In most cases, it was a shared effort between surgical team and an aesthetic team, but we had some cases where there were no documentation or the documentation was unclear. This slide outlines the main barriers we identified in implementing bedside magnet system for perioperative nutrition plans. These include staff turnover, high clinical workload, and gaps in MDT communication and documentation. Each issue is matched with targeted intervention. For example, regular teaching sessions for new staff members, easier access to magnets at the bedside so they could be placed during handover time, encouragement of standard communication between teams, integration of brief summary note for PACO instructions while surgical team is still not available. And we plan to do a second audit to check on these changes. So despite 75% compliance rate with magnet presence, discrepancies still occurred due to missing or contradictory plans. So moving forward, we plan to re-audit after implementing these changes.